Good evening.
Good evening, sir.
Thank you very much for joining in time.
I can see Rohit.
Yes, sir.
Dev Manlo. Yes.
I have seen him.
Yes, sir. I'm here.
Join.
Brojen. Where is Brojen? Brojen not available. Showman? No? Shobboshachi Panda?
Good evening, Amita. Can you hear me?
Yes.
Yeah, I just formally introduce, request Dr. Ranbir Prasad Singh to start the program. Today's program is on bladder tumor, and it will be conducted as a moderator come teacher by Dr. Amit Ghosh, who is the president-elect of EZUSI Urological Society of India and also the president director of Uro-Oncology section of USI. So he is the right topic with the right person, and with galaxy of teachers who will support you to get yourself comfortable for your examination. Dr. Dev Mando, Dr. Rohit, Dr. Brojen. I think there is some problem with Brojen because network, internet facilities in that area is not available due to the present problems in fall. So Brojen may not be available for the rest of the teachers and moderator Dr. Ghosh. I would request Dr. Ranbir Prasad Singh to welcome all of them to this evening program. Over to Dr. Ranbir Prasad Singh, sir.
Good evening, everyone. I welcome all the participants, coordinator, teachers, students, and all the supporting staff. This bladder tumor, now a lot of changes have occurred, and we are starting with the immunotherapy, where it has changed a vast sea of change in the immunotherapy. Starting, and we are mainly concerned with the bladder tumor, renal, and the prostate. Of other things are also there. Will be discussed in detail, and I request all of them, those who are not able to answer, others may answer. We should be clear on that topic itself. So please go ahead and all the best. Moderator, over to moderator, Dr. Amit Ghosh.
Thank you, Dr. Ranbir Singh. I think this has been a very good endeavor on behalf of the East Zone Council. I'm going to change the order a little bit with all your permission. All of them will be covered, but I'm going to start the discussion with the clinical case discussion number 1 so that it falls into order. Then I will come to the current status of immunotherapy. But one major topic I want to cover today, and then we will proceed from there. I will share my screen. I will ask, I think the faculty is Rohit and Dev Mallo today. Don't think others are available. And therefore,
Yes, sir.
Showman is not available. He's in the Ravindra Bharati music something.
Oh, achha.
So let us do whatever we can do. I'm going to start with the case now. Let me just share the screen. Give me one moment.
Please select the students also.
Recording in progress.
एक है। P1 না হতে গেল ইমিউনোথেরাপি নয় নেক্সট লেটারতে যাবে কেস নাম্বার 1 টা নেক্সট এটা হ্যাঁ ওকে ছেড়ে দাও আচ্ছা the students are Shubhajit, Abnesh Kumar, Sashi Prakash, Tilala, Manharlal. Are they all here?
Yes, sir.
Yes, sir. All of you are here. So, I will first of all, for the attention of Rohit and Remallo.
Yes, sir. Am I audible, sir?
Yes, this is the case. 65-year-old man presents in the OPD with a recurrent hematuria, an USG showing a 2-centimeter papillary lesion in the posterior wall of the bladder. This is the image. Yes. Now, Avanish.
Yes, sir.
You can see this image, can you?
Yes, sir. Yes, sir. I can.
Temperature lower, I'll keep low. This is the way we are going to proceed. Okay.
Yes.
Ask Dibmallo, take it over for the history of this case with Avanish.
Avnish.
Yes, sir.
So the patient has presented with hematuria, isn't it?
Yes, sir.
So what other information would you like to get about hematuria from this patient?
Now, first of all, let me be very precise. This is not something, this is a post-doctoral exam.
Yes, sir.
I want you to mention exactly what are the points you will highlight. Now, don't be an undergraduate, okay?
Yes, sir. Sir, I would like more information about the hematuria, whether it is initial hematuria, total hematuria, or terminal hematuria,
Very good.
and whether it is painful or painless hematuria, and if there is a clot, if there is history of clot, then what is the shape of clot, whether it is amorphous or serpentine clot. And I'll also ask about what is the occupation of the patient, and smoking history of smoking, and whether patient is on any anticoagulant or blood thinner, whether it is a first episode or a recurrent episode, and
It's a recurrent episode.
yes.
Pick up as much information as possible when the examiner gives you a slide like this.
Yes, sir. And I will ask about whether there is associated LUTS symptoms present with this or not, whether there is a flank pain associated with this or not, whether there is history of weight loss or loss of
Very
appetite.
good. Don't go over there. So what important precise points will help you to pinpoint your diagnosis to an bladder SLE? Just
Sir,
name those things.
If hematuria is gross and painless total hematuria, and the shape of clot is amorphous, and patient is having history of smoking or any history of
Excellent.
drug history of any paint industries or any chemical exposure history if present, and most likely it would be drug cancers.
So if you go through the newer European urology guidelines, you will find that the chemical exposures are now limited. Even a personal dye user, hair dye users are not now proven cases of forming a bladder tumor. So leave that alone. So smoking is the most important history, isn't it?
Yes,
So
sir.
it's an elderly gentleman with painless amorphous blood clots, recurrent, with history of smoking. Say. So what other histories would you like to elaborate?
Sir, other history, sir, lower unit tract symptoms associated with this or not?
Come to the medical history.
Medical history, sir, if there is any history of blood thinner or antiplatelet, if it is on antiplatelet drug.
Can diabetics present
Yes,
with
sir. Any comorbidity, whether it is his diabetic or.
He's asking something else. Listen to the question first of all.
Yes, sir. Diabetic, what medication he is taking? If he is taking pioglitazone.
don't go to pioglitazone. Again, pioglitazone is doubtful. Diabetics may present with multiple recurrent ACLs. This is one important point which has come up. So, sir, can we proceed to?
Rohit, have you got anything else to add on to this? Where is Rohit? Rohit,
Yes, sir. Am I audible?
very intermittently.
Am I audible?
Anyway, we proceed now.
Am I audible now?
Yes, better.
The only I like to highlight is that when people are asking a differential, they should have at least 4 differential diagnoses, 4 or 5 differential diagnosis in their mind when they are going to elucidate this.
So you want the differential diagnosis. Did you hear that, Avnesh?
Yes, sir. Sir, my different in view of hematuria, my differential diagnosis would be enlargement of prostate, whether it is benign or malignant, bladder tumor, and vesical calculus.
Dr. Vinash,
Yes, sir.
64-year painless recurrent hematuria. Three important differences.
Who's speaking? Who's speaking?
In serial order of preference. 64-year-old hematuria, 3 differential diagnoses in order of prevalence and importance.
Sir, urinary bladder mass,
Yes,
Uh,
good.
benign prostatic enlargement,
Yes, benign prostatic hyperplasia. Second,
and sir, CF prostate, sir.
yes, and you should not forget upper tract.
Upper tract.
Upper tracheal carcinoma.
Avnesh, try to think what the examiner is thinking.
Yes.
He has already hinted what he has wanted. 3 very relevant. There can be at least 10 causes, but he is wanting to pin you down to 3 main causes. So you mustn't forget upper tract. Very, very important. Very important. It can be a kidney tumor not behaving, not giving the perfect history. Okay, so that is more relevant because if you go into benign hypertrophy, if you go into something else which can cause image like a bladder stone, you see the whole history is different.
Yes.
It's painful, intermittent flow, and all sorts of other things, interruption of flow. So that is not what the examiner is wanting. So you know everything. We are here only to take care how you present yourself. Anyway, Nirmallo and Rohit, please now proceed to what investigations.
So before coming to investigations, can you just highlight what will be the examination findings? What you will look in examination?
Sir, I'd like to first. I would like general examination of the patient, whether he is anemic or not. If there is any palpable lymphadenopathy, vitals are stable or not, then I'll like to examine the systemic examination. Then
What are you talking about?
examination point of
No, no, what lymphadenopathy are you talking about? You said your principal diagnosis is bladder tumor. So I want to know, as a postdoctoral consultant, which group of lymph nodes would you want to palpate?
Sir, in general lymphadenopathy, sir, I would like to palpate.
General lymphadenopathy presenting with hematuria?
No, sir. As a part of my general examination, sir, I would like to just palpate the supraclavicular lymphadenopathy is present or not, sir.
Subclavicular. You mean to say you've jumped into a T4 bladder tumor type of thing? That's what you're thinking?
No, sir, as a part of general examination.
Look, let's be positive. I'm reminding you, this is a postdoctoral exam. Don't go, routine stuff like anemia. You can also say cyanosis is a part of general examination. That's not what we want in this exam. Okay? Anemia, I guess. Anything
Then, sir, anemia and sir, vitals. Patient is having hematuria, whether vitals are stable or not.
Okay.
Then I would like to examine, sir, systemic examination. Then, sir, per abdominal examination of external genitalia and distal rectal
You want to do a chest examination?
Yes, sir.
Why?
I want to, sir, auscultate the chest for if there is a equal breath sound is present or not. Because in case of
what are you wanting to do? Suppose you've already now committed that you wanted to do a cervical lymph node examination. You could have defended yourself. You did not.
Sir, in case of metastasis, sir, there may be
patient with 64-year-old with painless hematuria. You said you want to discuss and you want to examine anemia. You want to examine the lymph nodes. Okay, yes, I countered you. You could have countered me saying what? What pathology would present with anemia, lymphadenopathy, and hematuria?
Genitourinary tuberculosis may be presented.
Yeah. Speaking of tuberculosis, you could have defended yourself. That's what I'm trying to impress upon you. If you fall into trouble, you must find a way out. Or in other words, if you say something, you must be prepared, because the examiner may be unjustifiably antagonistic to your view. Okay? So you have to justify whatever you're saying, whatever, it doesn't matter. You can go and say, I want to examine his cervical spondylosis. You have to find out what the relationship of that is with your hematuria. Anyway, Rohit, you continue. Sorry, I interrupted. Carry on.
So, have you done your digital examination?
Yes, sir.
Have you mentioned DRE or have not mentioned?
I have mentioned, sir. I have mentioned about the external genitalia and distal rectal examination.
So in this case, DRE is going to be very important. And second, adding to Amit's sir's, in examination, you should be very specific. You should keep something hidden with you. You should not speak everything out. Let the examiner ask. Don't speak things around the periphery, otherwise you will be trapped. Act of omission is better than act of commission.
Exactly.
Omit. If the examiner asks you certain things, then only say. But don't go move around in the periphery too much. Limit yourself to the differential diagnosis that you have in your. That is just a general trick to avoid unnecessary questions that examiner may ask. Okay.
If I were to answer Rohit's question, I would have said, yes, I will examine his general condition. I will see whether he's anemic or not. I will see whether he has got a clear chest or not. And I will in details examine his abdomen, whether there is any lumps, whether his kidneys are palpable or not, whether any abnormal lumps in the pelvis. And I will also do a DRE. You will do a DRE?
Yes, sir, I will do.
Why do you want to do a DRE? You're not examining the prostate. Why do you want to do a DRE?
Sir,
in a differential diagnosis, you said bladder tumor. So why do you want to do a DRE?
Sir, to rule out my differential diagnosis, to to rule out the whether it is hematuria is due to the benign enlargement of prostate or is there is any
You
nodulative
really
present.
don't want your first diagnosis of bladder tumor. So
Yes.
DRE in this particular case, you are not curious to know whether you're dealing with a T4 bladder tumor or not.
Yes, sir.
Then
Locally advanced. I would like to know about this.
in this case, so DRE is not always associated with prostate. You have to get a lot of more information. What you're saying is right, but in this context, what I want to do by the end of this session, make you more relevant to this particular specific case.
Yes.
Don't answer out of a textbook. You are going to, the moment you finish this exam, this MCH, you are a consultant. Nobody to help you. It's you and the patient in front of you. Rohit, please continue.
So,
I think Rohit boss, I think the students should specifically say whether the bladder is palpable or not. That is a very important point in a bladder tumor case.
yes, true.
Carry on. We've gone 25 minutes now. Please carry on.
So considering that the examination findings are by and large normal, what are the relevant investigations you would like to order? And investigation should be very specific. When you see that the patient doesn't have pallor, then you should not necessarily go for a hemoglobin. So what are the relevant investigations that will help you in clinching the diagnosis?
I will ask for sir urine routine examination and urine cytology, then sir coagulation profile and ultrasonography, sir. Ultrasonography of the abdomen.
Debanlu, you want to take on his cytology?
So if the patient is having recurrent gross hematuria, would you
Yes,
like to have an cytology right now? The patient has presented to you with recurrent gross hematuria, isn't it?
Yes, sir.
So the patient is right now is having gross hematuria. Would you like to order an cytology right now or not?
No, sir. After ultrasonography, I'd like to do urine cytology.
So,
Why? Even if there is hematuria, you will do cytology.
Sir, in case of gross hematuria, urine cytology may not become positive, sir.
So urine cytology is difficult to see in a background of a lot of RBCs.
Yes, sir. Clump RBC.
Isn't it?
Yes,
so if you now we dwell into urinary cytology, what is the advantages and disadvantages of doing an urinary cytology?
Sir, urinary cytology is.
In other words, what is the ideal scenario when you would like to have an urinary cytology?
Ideal conditions are if a patient is having hematuria and there is no radiological evidence of any lesion in upper tract or the lower tract, then I will like to do urine cytology. And if patient is having persistent LUTS symptoms with hematuria, then I would like to do urine cytology.
Very good. So this is well defended. And if we continue this case with an urinary bladder as well, what will be the other indications of doing cytology? Say you are proceeding with this case.
Other indication, the tumor is located at the.
Would you like to have an urinary cytology in the follow-up of this patient?
Yes, sir.
After having the biopsy result with you?
After having biopsy report, yes, sir.
Okay. So what is the advantage of cytology over other urinary biomarkers?
It is mostly specific, sir, as compared to the other urinary markers.
You will take the
And-
first morning urine of what sample will you ask the patient? You take the first morning urine sample?
No, sir. We first morning sample should be discarded, and after that, first voided mid urine sample should be taken for the sampling.
Why do you discard the first void?
Because,
In the
sir,
morning.
overnight, because the overnight accumulation of the urine may distort the malignant cell, and there will be false negative result will be there.
How can you increase the yield of cytology?
Uh,
Have you seen an urinary sample posted on a slide? What stain do they do while doing urinary cytology?
A papinoculum.
Yes, it's a papinacular stain.
Papinoculum stain.
Yes. So, how would you increase the yield of urinary cytology?
Sir, we freshly taken sample of at least more than 50 ml, and will centrifuge the after doing centrifugation, you can increase the yield, sir.
Anything else?
We have to take 3 samples, sir, at least 3 samples to increase the yield.
Very good. Anything else? Have you heard about bladder barbotate?
Yes, sir.
What is that?
Come on, let's proceed. Come on.
So it's washing the bladder with your normal saline 3 times before collecting the urine, which actually dislodges the cell from the urinary epithelium. You can do an barbotage in the upper tract as well.
Yes.
So cytology in diagnostic purpose is when you have said it right, when you do not find a bladder tumor where you expect it to be, but the urinary cytology comes out positive, gives you an idea that this patient must be having an high-grade urothelial cancer somewhere in his urinary tract, isn't it?
Yes.
So summarily, it's an adjunct to cystoscopy. The sample has to be processed within 10 minutes, and you remember about the contamination. In the absence of any, this is what was being told, in absence of any lesion on cystoscopy or imaging, indicates lesion somewhere in the urinary tract. Okay?
Yes, sir.
Sensitivity is poor, particularly the low grade. Specificity is very high. Remember this slide. Then you will never forget that the high grade, there's nothing called G2 now, but this was the old slide, or whatever. The philosophy of this slide is,
As the grade increases, chances of the positivity is.
you've done that. It aims to detect exfoliated cancer cells, freshly voided urine, not the first voiding is a prerequisite. Okay. It has high sensitivity for detection of high-grade tumors and CIS. Please utter this word.
Carcinoma.
Make it your dharma whenever you are discussing bladder tumors. Please do not forget this entity during the exam. Okay?
Yes, sir.
It's an indicative of malignancy anywhere in the urinary tract and not only the bladder. That's the positive cytology. In the absence of a high-grade bladder lesion warrants random bladder biopsy. That's another thing. Prostatic urethral biopsy and evaluation of upper tracts. It's so important a subject. Your whole exam might finish with this. So this is the background knowledge you must have, that, you know, if you utter the word cytology, you must be very sure that you know how to process a cytology specimen, when to do it, when not to do it, what is the implication of it. Now, this Paris system. Rohit or Rapalu, would you like to just finish this with this slide?
If you look at the Paris system, the only thing that the examiner will ask you, I guess, that how do you differentiate between suspicious for high-grade urothelial carcinoma and high-grade urothelial carcinoma? What will be the differentiating point here? Where you have a very colorful slide in your textbook, colorful figure in your textbook. How do you differentiate between suspicious for high-grade urothelial carcinoma and high-grade urothelial carcinoma?
Sir,
Because
depending upon the mitotic count, high mitotic count will be there, sir.
very good.
Dysplasia and
No,
nuclei.
do not go to the dysplasia. Very good. So it is the cells which have high mitotic count. Excellent, excellent. What is the drawback of cytology? This is the last point.
Sir, drawback, sir, in case of gross hematuria, it may be a false, in that case, maybe false negative report. And
What is your practical implication? You have treated bladder cancer in your OPDs and in your IPDs, isn't it?
yes,
What is the practical implication? Why do this typically cytology fails in patients who are treated with BCG? You know this?
sir, first interpretation by the pathologist, second, sir, proper collection collection of the sample by the patient is not.
BCG leads to abnormal findings in urinary cytology. So pathologists may report it as suspicious of high-grade urothelial cancer because there are changes in BCG with formation of, multinucleated giant cells
Yes, sir. Yes.
in urinary cytology, isn't it?
Yes, sir.
So that may lead to a false impression of recurrence of bladder cancer.
Right. So we've dealt with enough of cytology because this is the weak point. People sometimes say this, some people fascination for it. Now you have got a reasonable idea as to what you face in cytology if you say so. And what is the status of cytology in a Viva exam? Now, what is the next line of investigation? What should it be? In this particular patient, 64-year-old recurrent hematuria. Quick, come on. What is the next?
Ultrasonography of the
Ultrasonography.
abdomen.
Rohit, would you like to sort of take this on?
I think the ultrasound picture was shown in this case.
Yeah. Let's proceed. What do you want to know from the ultrasound?
Sir,
Rohit is off, I think. Yeah, Rohit.
No, sir,
Carry on.
the next thing is that you have the ultrasound picture in front of you. Apart from this, do you think that you need any other investigation? And what are the things that you see in ultrasound?
Yeah.
sir,
What
in
are the
ultrasound,
point wise?
ultrasound, sir, I would like to see the size of the space occupied lesion, site,
Yes, good. Size,
site, number,
size,
sir. Whether it is papillary or sessile, whether it's broad base or papillary lesion.
And
And sir, if it is located near to the trigonal area or ureteric orifice, then I would like to see, is there any hydronephrosis? Is there or not?
scan the upper tract.
Yes.
So in this particular case, do you think ultrasound is enough, or you would like to add some other investigation? And why?
Sir, in this case, sir, I'd like to do CT urography, sir, just to for to complete, sir, as this patient is presented with hematuria, as a hematuria protocol, I would like to know about the
why do you want to do a CT?
Yes,
Photograph-
why you want CT scan? In this case,
In this particular case?
Sir, size was what, sir, in this case?
2 centimeters.
Two,
I think sir mentioned in his slide it was a 2 centimeter bladder tumor.
2 centimeters, sir. Then, sir, I'll omit for this case, sir.
So my next question is, when you will go for CT scan when you have bladder tumor on ultrasound?
Sir, if size is more than 3 centimeter and if there is a hydronephrosis present
Yes.
and
Let me interrupt once again. Let me finish this ultrasound business. What are the points that you see? It's not complete, Rohit. We need to, Avinash, we need to really complete your list and be very smart about it. You have said size. You have said number. What else do you want to know in an ultrasound? Huh?
so where it is located, and is
Location.
there, yes, sir,
Then
hydronephrosis is present or not?
you say
Is there?
that. Now you're saying hydronephrosis. Okay. Why hydronephrosis? Why are you so fussed about hydronephrosis?
Sir, if tumor is located near to the ureteric orifice, there may be hydronephrosis and it is suggestive of muscle invasiveness.
Okay. Anything else?
And I would like to know about the bladder wall, whether it is thickened or mucosal irregularity is present.
What has
Do you think bladder tumor causes bladder wall thickening?
Bladder tumor, no, sir, but patient is having patient is of 64-year age. Maybe
The important thing is you should not say things which are not relevant. The way your exam is going or the flow is going, there is no relevance of bladder wall. You are not examining a case of BPH or LUTS, or neither it is a case where the bladder tumor is creating obstructive LUTS. So you should be very specific when you are answering the question. So you have, I think, mentioned the site, the size, the number, where trigonal, bladder neck, or any hydronephrosis is there or not. So apart from that, anything you would like to add, Amit sir?
What about the
I think,
position?
sir,
What about the position do you want to know?
I think he mentioned that whether trigon is involved or not, whether
Mention
bladder
that?
neck.
Okay. Sorry, I missed that. Yeah. Okay.
He mentioned about trigon and bladder neck.
So, what is your next step in this particular case?
in this particular case, sir, I like to do cystoscopy, sir.
Not a CT scan.
As the tumor is of size 2 centimeter, we can omit CT scan, sir. We can directly
Which
go.
cases? I'll let Rohit handle this. Which cases do you do a CT scan? Forget about this case.
I think I asked this question. When you will do a CT scan, when ultrasound, what are the findings on ultrasound or CT scan which will suggest that you need a CT scan?
Sir, if tumor is more of size more than 3 centimeter, if it is broad based, sessile tumor, if it is multiple and if it is involving bladder neck or near to the trigonal area or near to the ureteric orifice, if there is hydronephrosis on the ultrasound, then we'll go for CT urography.
Yes, very good. So now, Amit sir, I think you are ready with the slide of CT scan.
Yeah. So it gives you, what information does it give you? Number,
Sir,
location, size of
it
the
will-
or more
size.
size. So it gives you more information about the muscle invasiveness of the disease. Hmm?
Yes, sir.
Chest imaging, not required in NMIBC. In cases with raised hydronephrosis inserted, CT scan performed after TURBT reveal perivecycle fat stranding. When would you ever do a magnetic resonance imaging? I'm trying
Yes,
to
sir.
finish your role in imaging. This is not the sequence in this particular case.
Sir, if the tumor is broad based and if in CT if we are suspecting, first of all our indication, if CT if we can't do CT scan because of the raised creatinine or impairment of the renal function, then we'll do MRI. And if CT or ultrasound finds suggestive of extra cycle extension, but the fat plane is lost, then we'll do MRI.
This is what you mean.
Yes, sir.
You
Wire
should not say when the creatinine is raised, you can go for MRI. You want to say that you can give a contrast in MRI in patients of CKD.
You can use the urine as a contrast. But,
urography, yes, urine
but,
enact as a contrast.
when the creatinine is raised, the GFR is low, you cannot use gadolinium as a contrast.
So the next question is, are there any contrasts in MRI which can be given in cases of patients with CKD?
I can't see you. Where are you?
You don't know, it's fine, but you should read it. And what is the side effect if you give gadolinium contrast in patients with in patients with CKD?
There is a risk of systemic fibrosis in case of
It is NSF, not systemic, nephrogenic systemic fibrosis.
nephrogenic.
Finally, would you ever do a PET CT for a bladder tumor? I'm not talking about this case. I'll come back to this case.
Sir, PET scan is not recommended.
Which PET will you do? I'm trying to clarify your thoughts on a imaging and bladder tumor.
Sir, PET scan is not indicated, but
suppose somebody comes with an FDG PET, what would you find in that?
I can see lymph node status in
Yes,
PET scan.
you will find metastasis. It is
Yes,
not
sir.
good for analyzing the tumor per se. Yeah, very limited.
Metastasis workup.
With localized bladder cancer, it may have a role detecting metastasis to other sites. Yeah, so your thoughts has to be very, very clear. So coming back to this particular case, now Debmallo, can you take him on? Imaging part we've completed. We have completed cytology. Now we go back to the original case. 64-year-old recurrent tumor. Is there any other student who would like to volunteer? I think we've made him sweat a lot. Avnish, would you like to take some rest? Who is your enemy now? Who's your next
Who
enemy?
is volunteering?
Huh?
Shashi.
Shubhajit, who is volunteering? Come on, give
Shashi,
Avnish a rest. Have you run away or what? What about the other students? Avnish, have you made them run away?
Yes, sir. I'm here, sir. Hello.
Okay.
Yes, sir. Yes, sir. I'm here, sir. I'm Sasi Prakash here, sir.
Mallo and Rohit.
Shashi is here.
Sashi is here. So Sashi, we go
Yes,
back to
yes,
the
sir.
particular case, 64-year-old recurrent hematuria. And this is the tumor. We've discussed the roles of imaging. We've already got a sonography done. We've also decided we don't need a CT scan. Decided the role of MRIs in general, decided the role of PET CT in general. I hope there is clarity about imaging in bladder tumor. Now let us come back to a practical case. This is the patient in front of you in the clinic. He wants an answer. What is the next step? What are you going to do? Over to Devmallo and Rohit, please.
Shashi, what is the next thing you will do? Your diagnosis is clear. Now, what is the next important step in this case? Shashi,
I'm
am I
preparing.
audible?
Yes, sir. Yes, sir. Yes, sir.
So,
Yes.
what is the next step?
Next is prepare this patient for cystoscopy and biopsy, TURBT.
So what you
Cystoscopy and biopsy or cystoscopy and TURBT, which one? What sort of biopsy are you going to take?
No, sir. Cystoscopy and TURBT, sir.
Okay, thank you.
So
What sort of cystoscopy? Blue light cystoscopy?
You told you
Yes, sir.
Somebody's talking in the background. Somebody is talking in the background. What sort of cystoscopy, Shashi?
White light cystoscopy.
White light cystoscopy. Wait, please continue.
you told you will prepare for cystoscopy. So what you will prepare? You told that I will prepare for cystoscopy. So what is included in preparation? What are the investigations that you need for taking the patient for cystoscopy? Am I?
Sir, why voice is interrupted in between?
So what are the investigations, most important investigations before you take the patient for cystoscopy?
Yes, sir. We have done investigations regarding the anesthesia point of view after the once diagnosis is completed. So I have done hemoglobin, WBC count, serum creatinine, and PTINR. PTI.
More important from your side, you should always have a pre-op urine culture.
Yes, sir. I have always have done urine routine culture first.
Write the steps of cystoscopy and TURBT in sequence. Don't start saying in different directions. In sequence. The patient is prepped and drepped in social lithotomy position. Now what? How will you go around with your cystoscopy?
First of all, we start cystoscopy from the urethroscopy, and we examine whole of the urethra with the scope, along with the prostate and bladder neck. Then we want to see each and every aspect of the bladder.
Sorry, Sashi. Let me just interrupt.
Before starting cystoscopy, will you do anything?
Before starting bimanual examination, sorry, sir.
Don't forget.
Yes, sir. Before cystoscopy, I do bimanual examination.
Will you always do a general anesthesia?
No, sir. If a patient is on lateral side and large mass and broad waist mass, then we prefer general anesthesia.
How do you know?
Otherwise, for
how do you know?
Sir, previously from previous investigations, sir.
What
Otherwise, we prefer general.
Investigation will guarantee you that the thing is on the posterior wall and there is no lateral tumor. That is why you're doing a cystoscopy. No, Sashi, let's be very clear. Our patient has to be obturator jerk free. That's your philosophy. So yes, you are at liberty to choose any sort of anesthesia as long as your obturator jerk is not going to trouble you. So yes, either you've got two choices. Either you give general anesthesia and paralyze the patient, or you give a spinal anesthesia and you've got an anesthetist who can block the obturator. No other choice. So you're a surgeon. Please be more definitive. Don't waffle on the exam. Okay? Either you do this or you do that. It's not your wish. You can't leave it to chance. So safest answer is under general anesthesia, and if the examiner questions you, you can always say that is the practice in your hospital. If you want to face the music of can you do it in under spinal, you will have to qualify the answer saying that I will have to have an obturator block. Our anesthetist is not good at that.
Yes.
Yeah. So that is what you need to see. Then you start the. So Rohit, are we okay to go ahead with the cystoscopy now?
So what things see in cystoscopy? Step by step.
We missed you. We missed you.
What are the things you will see in cystoscopy step by step? Shashi?
Yes, sir. In,
Come on, Shashi, he's asking you step by step, what are the things that you will do? Your patient is under general anesthesia.
Sir, first of all, we want to inspect the whole of the bladder from the urethra, bladder, neck, prostate, then trigonal area, bilateral ureteric orifice, anterior and posterior wall of and lateral wall of the bladder and the dome, and we want to know about the what is the number, site, and size of the mass, and any other mass present or not.
Okay.
Any.
So you have seen all, you mentioned all the areas that you will see. You have mentioned that you will see the site, size, and number. Particularly interested to see whether there is anything in the dome or in the trigone or in the lateral wall.
Yes.
What else do you want to see?
Any abnormal area, sir. Any.
Oh, you want me to, we want the examiner to mention that? Huh? You're doing a final exam, you should be 1, 2, 3 finished. Okay, let's not waffle. We need to know all the areas, how many tumors, what is the position, what is the size, what is the nature of the tumor, whether it is solid, whether it is papillary, does it look that it has got a muscle invasion or not? You can say that, can't you? With enough experience, you can say that. You've already bimanually palpated it.
Yes.
Yeah? You've already bimanually palpated it. Come on, be more smart about it. This is your final exam.
Any abnormal looking urothelium, then what else?
If any abnormal looking urothelium, then we want to get biopsy from that side also.
That's fine. That is fine. But there might be other areas where doing a TURBT might be dangerous. What are those specific areas? Name one. You frequently get, you may get a tumor in that area, in that specific pathology, while doing a TURBT may be dangerous.
Near about ureteric orifice and domes.
No. If there is a tumor near the ureteric orifice, you just cut the ureteric orifice. That is what you do. Dome is a dangerous area. What is other area? What is that other area where you keep yourself on tiptoes in a diverticulum, isn't it?
Yes, yes.
So dome and diverticulum, these are the 2 Ds. If you had access to all forms of technology, what other form of cystoscopy did you know that you can do?
So the blue light cystoscopy.
Okay. What is it? Very quickly, you're running out of time.
Sir, we use hexaminolevulinic acid or aminolevulinic acid beforehand, 1 to 2 hours before the cystoscopy, and we do blue light cystoscopy. And
no, what's the mechanism? What happens to that? What happens to it? What happens to it?
Sir, if the tumor cells pick up these wavelength, and it emits higher energy wavelength during the cystoscopy. So we get red areas out of a blue background during blue light cystoscopy.
That's the technique. You can read this. You have to be aware about this, huh?
Yes.
What is available in India? What enhancement technique is available in India? Have you seen a blue light cystoscopy?
No, sir, I have not.
Is there any enhancement technique available in India?
Sir, narrow band image.
Very good. Excellent.
What is that?
Which
Sir,
Is that?
Sir, Olympus having inbuilt narrow band imaging system.
What is that? I don't want to know an Olympus or whatever.
Well, what is the principle? Sir is asking the principle of narrowband imaging.
Sir, there are 2 wavelengths, 450 and 514 nanometer wavelengths, which are emitted by the.
Anyway, carry on.
Sir. Yes, sir. emitted by the urothelial cells, and it get a green and brown background, green and brown cells out of the pink and white background.
Okay. So you actually detect a more dense submucosal vessels out of it,
Yes.
isn't it? So,
Yes.
You have now detected a lot of bladder tumors. Say it is multifocal. Even the ultrasound shows it to be multifocal because there is a suspicious tumor in the anterior wall as well. So, can you describe an ideal TURBT? Describe an ideal TURBT. How will you proceed to do an TURBT? Say it is in the posterior wall, like the patient you have present.
So
Describe
if
an ideal
I have,
TURBT.
so ideal TURBT we have on the posterior wall of bladder tumor. We do TURBT with available energy sources, either monopolar or bipolar energy, and we want to do a piecemeal resection from and we after the and get a normal area around the tumor also, and we want to visually clear TURBT at the end
Why do you start the
with
TURBT
good
from?
hemostasis.
Why do you start the TURBT from? You have entered the bladder. You have seen a tumor, 2 centimeter tumor at the posterior wall, and at the very outset, you start resecting from the from your distal end, from the very end you are presented to. Now you
No,
see
sir.
the
At
now you
the
see the normal urothelium beyond the tumor, isn't it? You
yes,
first
yes,
you
yes.
first set your goal of a tumor-free flow, isn't it? And then you say,
Yes.
as you have mentioned, that you also resect 1 to 2 centimeter beyond the
Tumor.
margin of the tumor base.
Tumor.
And why
Yes.
is that?
So
Why do you resect beyond 1 to 2 centimeter of the visual tumor base margin? Because tumor bases often have papillary projections, extension beyond the visible margin along the depth.
Would you take random biopsy in this particular case?
yes, sir.
You will.
In this
Yes,
particular
sir.
question is, will you take random biopsy in this particular case?
No, sir. No, sir.
Why?
No, sir. Sir, there is no suspicious area after that. After the single tumor, so I'm not taking random
I will
biopsies in this case.
question in another way. Sir is asking you, in this case, when you will take random biopsy?
If there is no visible mass and cystoscopy is positive, sorry, cytology is positive, then we take a random biopsy.
Or if the tumor is looking low grade, papillary tumor, and the cytology is positive. Or if there is
Cytology is positive, yes,
or
yes, then we take a random biopsy.
Okay, so the patient has you've done your TURBT. Now you're finishing it. You've done your resection, you've done your hemostasis. What do you want to do now?
So it's we want to irrigation, bladder irrigation, sir.
Are also छोड़ो ना. Don't be silly. What
asking,
you want to do?
after TURBT, will you do something in this case?
Sir, this is a single papilliferous 2 centimeter mass, so we may go through may opt for the mitomycin C into psychotherapy.
Are you going to do an examination or anesthesia in this particular case again? We haven't come out of the OT yet.
Yes, sir. After OTs.
No, no.
With-
You do a bimanual examination after TURBT.
Yes, sir.
Okay,
We
and
complete.
not.
We do, sir. We complete bimanual examination after the TURBT.
Why? Why?
To know the extent of the tumor, sir. It differentiate between the T2 and T3 tumor, sir. If bimanually mass is palpable before the TURBT and it's not palpable after that, then it most probably it is T2, and if it is palpable after TURBT, then it is T3, sir. So it can differentiate between T2 to T3, but in that case.
So, sir, would you like to add something from what we have discussed in cystoscopy, sir? Because I am sure of cystoscopy here. To Amit Ghosh, sir.
Hello.
Am I audible?
Intermittently.
Yes, sir. Will you like?
Next is, you were talking about bladder installation. What is the policy that you follow? Where is Debmallo? Can you take this question, please? Rohit or Debmallo, please take on. He's finished his TURBT.
Sir, I will reframe this question. Sir is basically asking, when you give the patient mitomycin in the post-op area as an adjuvant therapy, what are the criteria when you say this patient or mitomycin C?
Sir, if there is a TA low, tumor look like a TA low grade tumor, and there is no perforation or hematuria or extensive resection, then we omit it. Otherwise, for a low grade tumor, we prefer mitomycin C within 6 hours of the TURBT, and maybe we go up to the 24 hours.
So, should we go ahead, sir? Question. Or would you like to add anything?
No, that's okay. That's fine. Now he has now been discharged. What do you want to do now? What's your follow-up plan?
One question
Sir,
will ask. Shashi, only one question before. What are the complications following TURBT? Just enumerate the complications of TURBT.
Sir, first hematuria and hematuria, perforation, and post hematuria, perforation, and the most common intraoperative complications are in TURBT, sir, and
Okay, fine. So now in OPD, what you will see in biopsy, I think Ghosh sir was asking that question only. What you will see in biopsy?
Sir, in biopsy, we want to know about the this tumor is which type of tumor is it, urothelial carcinoma, and what depth it is. Either it is involve only mucosa or lamina propria or muscles, and
Let's put it in the urological language, okay? Not this, that, and the other. You want to know the grade of the tumor. You want to know the stage of the tumor as per biopsy. You want to know whether there is any variant. You want to know whether there is an associated CIS. Speak the urological language, please.
Yes.
You have to be smart in your answers. You will pass the exam first shot. Even if you can't answer after that. These are very standard questions. What are you going to see in the biopsy? Suppose the biopsy comes as PT1 high grade. He has come to you and he's seeing you. He has no hematuria, no complications. He's sitting in your clinic and he says, what next? What will you tell them?
Sir, we plan for a restage TURBT.
You plan for a restage TURBT?
Yes, sir.
In all cases?
No, sir. T1 high grade, sir.
When do you want to do it?
Sir, if there tumor is T1 or TA
No, no,
high grade,
when? What time?
within 6 weeks, sir.
Preferably within 4 weeks, before it has completely, completely scarred. Okay? You don't want to wait till 6 weeks. Okay? As soon as possible. Earlier, more closer to 4 weeks than 6 weeks. Philosophy is the earlier the better. If at 6 weeks it forms a scar, you've lost your chance. What do you want to do? What do you want to see in the RTURBT?
In RTURBT, we want to know any upgradation of stage, sir.
So you're going to do a RTURBT irrespective of whether you have had muscle in your first biopsy or not.
Yes, sir.
Always.
No, sir. If muscle is involved, then not. Otherwise, if muscle is present and not involved, or muscle is not seen, in both cases, we go through the restrictive.
What is the muscle that you can see in biopsy? What types of various kind of muscles that you can see in a biopsy? In reframe the question, do you know what is muscularis mucosa and muscularis propria?
Sir, muscularis mucosa is some superficial, sir, above the lamina propria, and muscularis propria is the deep muscle which we want to.
It is in the lamina, not superficial. It is in the deeper layers of lamina propria, and the muscularis propria is the detrusor.
Yes.
Okay.
We missed out one thing during the exam, during the cystoscopy. Would you have liked to do a prostatic urethral biopsy? If not, when do you do a prostatic urethral biopsy?
If there is if any suspicious area in prostate during the scopy,
No.
There is a
Listen, this is the indication, okay? For shortage of time, I'm
bladder
not.
neck tumor, sir.
This is exactly what you do, okay? There are some locations and some associations where you actually do indicated prostatic urethral biopsies. So you are clear about random biopsies, you're clear about prostatic urethral biopsies, you're clear about restaging TURBTs, yeah?
Yes, sir.
Right. Now let me see what is left. Okay. Now, in the clinic, what is your next motive? While you're looking at the biopsy, it has nothing to do with the patient. What is your next plan? Let's get hold of somebody else. We want some rest.
T1 G3, na, the final thing that it is a T1 G3, the restage bladder tumor, there is no evidence of malignancy. I think that is the final. Now next what? T1 G3 with no evidence of muscular lesion even in a restage TURBT. So what next? That is the question I think sir is asking.
The risk stratification. What should go through your mind is, what risk am I going to allocate this patient?
Yes, sir.
You have finished your investigations. We've gone through your process of TURBT. We've gone through the criteria of random biopsies, prostatic biopsies. We've done the re-TURBT. But now the patient is in the clinic and you are thinking, what risk stratification am I going to get into?
Yes.
You know this. You know this slide, don't you?
Yes.
Yes.
Do you know this one? You know this thing?
What do you know about the intermediate grade? Shashi, sir is asking that. Do you think that intermediate grade is relevant or it is totally out of picture now?
Sir, relevant intermediate risk is also relevant, sir.
No, it's not risk, it's grade.
No, sir. Intermediate grade in sir, given usually we use now PUN-LMP low grade and high grade, sir. So,
but are there any guidance which still mentions intermediate grade?
What factors do you take into account for risk stratification? Do you know anything? What's going on in the latest market?
Sir, for risk stratification, sir, we want to know about the stage of the tumor. its grading, and its size, and it's a primary or recurrent, or
What?
it's primary or recurrent.
What do you mean primary or recurrent?
Sir,
I'm
for a risk,
asking you, what are the other factors that you take into risk stratification? One is the grading.
yes, sir.
Okay.
Yes, sir.
Either you say high grade, low grade, or you say G1, G2, G3, whatever. And you
Yes, sir.
decide what you want to do. Both of them are in vogue.
Yes, sir.
You definitely have to know whether it's CIS positive or not.
Yes.
You also want to know
Size.
age, size, whether it's a T1 lesion or not. And then you risk stratification.
Risk stratified.
चलो
Yeah.
चलो
I'm not going to get into this. We don't have time for all this. Yeah. But you really need to know that you will have to, will somebody silence somebody's baby is protesting against this class. Somebody's baby is protesting against this class. Let's not be rude to the baby. Let us discipline ourselves. We don't want this noise. Okay. This is the clinical importance. Shashi,
Yes.
I'm talking to
Yes,
you.
sir. Yes, sir.
So classify yourself. Whenever you're getting a case in the clinic as a hematuria, we've gone through the whole rigmarole. You take a good history. What is the history? Summarize it.
64-year-old male came with the recurrent hematuria.
What are the points you're interested in? You're interested in the age. You're interested in the hematuria, whether it's painless or painful. You're interested in the character of the hematuria, whether it is total, terminal, or whatever. Then you're interested in whether it is associated with clots and what is the nature of the clots. Then you're associated with what is the history of smoking or not, whether it is associated with any diabetic medication or not, whether it is associated with fitness or not. Yeah. Then you are going to tell the patient, right, we want an ultrasound. Then you characterize what your ultrasound is going to say. This is the flow chart I'm talking about. If on the ultrasound you're happy, you proceed to either in two directions, either to do a decision to do a TURBT, a cystoscopy TURBT, or you judge for yourself whether you're going to do a CT scan then and there or later. That's a very important question for your exam. You can go either way. You have to justify. You can do an upfront CT scan. You can do the CT scan a few weeks after your initial TURBT. Yeah. If it is obvious to you that it is not muscle invasive, you can wait. You don't necessarily have to do it. You also know what the role of CT scan is. You also know what the role of MRI is. And you also know MRI more relevant in a muscle invasive bladder tumor. PET CT relevant only in if you have. आपको शौक होगा तो करना, not necessary. अगर करना है, if you really have to do it, all information that you will get in an FDG PET is about the metastasis.
Lymph node and
any metastasis. Why lymph node only? It will pick up anything else also. It will pick up the bone metastasis also. So you want to know. If you're not interested, if you're convinced it's a T4 mass, you don't order. If you are ordering a thing, you are doing. So then when he comes back, you're looking at risk stratification, depending on the grade, the age, the size, and the associated CSI or CIS or not. Okay?
yes.
This much for today on this. Now we've got some time. Sorry, anybody saying anything?
No, to Shashi, where you put this patient in risk stratification, this patient. Now it is a muscle involved, you know the history.
Yes, sir. Sir, we risk stratified patient after the re-stage TURBT, sir.
Yes, no evidence of malignancy in the detrusor muscle. In
Yes,
the
sir.
re-stage TURBT, you get the report that there is no evidence of malignancy in detrusor. So where you will place?
Sir, this is high risk tumor.
Okay, very good.
Yes.
Next.
Now we would invite, if this is finished,
Yes, sir.
we will like to know who is presenting current status of immunotherapy in bladder cancer. One of you, who's doing that?
Sir, I'll be. Am I audible?
You are doing it?
Yes. Yes, sir. Yes, sir.
Your topic is current status of immunotherapy in bladder cancer. Please try and finish this within 6 to 8 minutes.
Okay. Okay. Sir.
Immunotherapy in breast. Okay. I really want to know what is your view on this subject. Don't give me a long 1-hour lecture on this. I'm going to stop you at 6 to 7 minutes. Come on, let's go.
Can I share my?
Stop share. I'm to stop share. Okay. Yeah, Shantanu? Shantanu, are you trying?
Yes, sir. I'm trying. Sir, is it visible?
No, nothing has happened.
Not sure.
Maybe Ruma can help. Ruma, are you on? There he is. I think something's coming up.
Sir, is my screen visible?
No, not yet. It says now it's visible. Yeah, it's visible.
Good evening, teachers. My topic
Your
is
time
current
starts
status of.
now. It's 8:20. I will be off by 8:27.
So speak on the relevant.
As we all know, bladder cancer is the 6th most commonly diagnosed
I
cancer.
don't want to
in
know
men.
that. I don't want to know that. I don't want to know that. I want to know immunotherapy in bladder cancer. I don't want to know if it's 6th yet.
Okay. So immunotherapy in bladder cancer, first non-muscle invasive bladder cancer, BCG is the oldest immunotherapy which was used in bladder cancer. So the pathogenesis, the mechanism of action is that the process begins with the installation of Mycobacterium, the bacteria, which adheres to the urothelium via fibronectin protein, which leads to release of IL-8 and TNF-alpha, which activates the macrophages and in turn activates the dendritic cell, which in turn stimulates CD4 T cells and activate lymphocytes and target the antigens and tumor-specific antigens. So this is the mechanism of action for BCG. So the BCG reduces the reduction in recurrence rate by 32% and progression rate by 27%. So coming on to the BCG toxicity, it is more toxic than toxicities more than intravesical chemotherapy. Serious side effects are noted in less than 5%, and BCG infection is noted in 1% of the cases. Then it should be used with caution, or it is usually contraindicated in immune compromised patients. These are some of the side effects of the BCG therapy. The local side effects include.
This is not your topic. Just skip this slide, please.
Okay. Sir, these are the contraindication, absolute and relative contraindication of BCG therapy. Absolute contraindication
We'll deal with BCG therapy later. I wanted to know, the first few slides were fantastic.
Okay. So these are the current EAU guidelines for BCG installation, contraindications of BCG installation. These are in first 2 weeks of TURBT in patients with visible hematuria or traumatic catheterization, in patients with symptomatic urinary tract infection. There is a strong evidence of contraindication of BCG in such cases. So BCG schedule, the induction dose is 6 installation, weekly installation for 6 weeks, then maintenance for 1 years or 3 years, depending upon the risk stratification of the patient. So in high risk patients, we usually go for 3 years of maintenance dose. So these are the recommendations for BCG. For high risk tumors, full dose of BCG induction along with the installation of 3-weekly installation at 3, 6, 12, 18, and 24, 30, and 36 months. These have a strong recommendation in EAU guidelines currently. Then intravesical BCG is also used in CIS, which reduce the risk of progression of CIS by 35%. So now coming on to the immunotherapy in muscle invasive bladder cancer. So these are recently developed agents in the past 7 to 8 years. These includes immune checkpoint inhibitors. These are PD-1 inhibitors, which includes pembrolizumab, nivolumab, PD-L1 inhibitors, atezolizumab, durvalumab, and avelumab, and CTLA-4 antibodies, which includes ipilimumab and tremelimumab. So PD-1 is usually expressed on T cells, and it binds to its ligand PD-L1, which is expressed on tumor cells. So PD-1 plus PD-L1 leads to limit in T cells proliferation, and it reduces the capacity of killing capacity of the T cells. Moreover, this CTLA4, the mechanism is these are expressed on T cells. Then usually they are expressed on regulator T cells, which regulator T cells which have a suppressive action on CD8 T cells. So this anti-CTLA4, this binds with the CTL4 LA4 receptor, and this reduces the suppressive action of this regulator T cells, thus enhancing the immune response. So these are the agents, different agents as described before. So these agents are currently approved by FDA in the management of bladder cancer. These includes the agents have already been described before, and these are the clinical trials leading to the FDA approval of these agents. So in different areas of role of immunotherapy. In neoadjuvant immunotherapy and chemoimmunotherapy, the checkpoint inhibitors are increasingly tested in a neoadjuvant setting, either as monotherapy or combination with chemotherapy. The results of phase 2 trial using PD-1 inhibitor pembrolizumab reported a complete pathological remission in 42% of the cases, and partial response in 50% of the cases. In single arm phase 2 trial with atezolizumab, a pathological complete response was noted in 31% of the cases. In the recent published update of Abacus trial using single agent atezolizumab, the 2 years disease-free survival and over survival was 68 and 70%, 77% respectively. So these are the current indications of neoadjuvant this immunotherapy. So currently EAU does not recommend routine immunotherapy, but it can be only be done in patients with clinical trial setting where it can be offered to the patients. The role in coming on to the role in adjuvant immunotherapy to determine the benefit of PD-1, PD-L1 checkpoint inhibitors, 3 RCT have evaluated checkpoint inhibitors monotherapy with atezolizumab, nivolumab, and pembrolizumab in patients with muscle invasive bladder cancer. So the checkmate trial, it is a double-blinded RCT which investigated adjuvant nivolumab versus placebo for 1 year in 709 patients, which demonstrated a significant improvement in median disease-free survival of 20.8 months with the nivolumab as compared to 10.8 months with placebo. So the percentage of patients who were alive in the and disease-free at 6 months was 74.9% with nivolumab versus 60.3% with placebo. So the FDA has approved nivolumab for adjuvant treatment of patients with bladder cancer who are at high risk of recurrence after undergoing surgery, whereas EMA has approved adjuvant nivolumab for the treatment of adults with muscle invasive bladder cancer with tumor cell PD-L1 expression greater than 1%, who are at high risk of recurrence after undergoing radical resection. These high risk of recurrence includes PT3, T4, and pathological any lymph node positivity. So these are the current recommendation of use of immunotherapy. So adjuvant nivolumab can be offered to selected patients with T3, T4, and N plus pathological and disease not eligible for or who have declined adjuvant cisplatin-based chemotherapy. Still, the cisplatin-based chemotherapy is the gold standard, but in the patients who are not eligible or who have denied can be used. So immunotherapy. So integration of immunotherapy in the first line management of chemotherapy, in the first line chemotherapy treatment of patients fit for platinum. So in this, there are two trial, IMvigor trial, in which atezolizumab plus platinum gemcitabine chemotherapy versus chemotherapy plus placebo was done, in which there was progression-free survival was greater with combination of atezolizumab 8.2 months versus 6.3 months, but the overall survival was not significantly increased. And keynote trial tried investigated the role of adding pembrolizumab with platinum-based chemotherapy, but the results were there was no significant difference in overall survival and progression-free survival. So in conclusion, these three trials do not support the use of combination of PD-L1 checkpoint inhibitors plus chemotherapy or any combination as first-line treatment. So immunotherapy in patients unfit for cisplatin-based chemotherapy. So in this, pembrolizumab and atezolizumab have been approved by US FDA and EMF as a first-line treatment of treatment in patients who are cisplatin unfit patients in case of positive PD-L1 status, or PD-L1 positivity for use of pembrolizumab is defined by immunohistochemistry as of CPS greater than 10 using DECO 22C33 platform. And for atezolizumab, the positivity of greater than 5% tumor infiltrating immune cells with using Ventana SP142 system. So the combination of carboplatin and gemcitabine is still the preferred first line treatment in which cisplatin is contraindicated, but these agents are also FDA. So also switch maintenance with immunotherapy after platinum based chemotherapy. In this Javelin Bladder 100 study has been done in patients who achieved the stable disease or better after 4 to 6 cycles of platinum gemcitabine were randomized to avelumab and best supportive care treatment. So overall survival was greater with avelumab arm as compared to 14.3 months in BSC arm. So in 2020, avelumab received FDA approval for treatment of patients with locally advanced or metastatic bladder cancer that has not progressed with first-line platinum-containing chemotherapy. So this immunotherapy are also used as a second-line immunotherapy for platinum pre-treated patients. In this, the pembrolizumab, nivolumab, atezolizumab, avelumab, and durvalumab have demonstrated similar efficacy and safety in patients progressing during or after previous platinum-based chemotherapy in phase 1, 2, and 3 trials. So for patient unfit for platinum-based chemotherapy, FDA approved pembrolizumab and atezolizumab as a first-line treatment for patient unfit for platinum-based chemotherapy. So these are the current recommendations. So now this is the treatment flowchart of metastatic urothelial carcinoma. As you can see, if the patient is platinum ineligible, then we can test PD-L1. And if the PD-L1 is positive, then we can order as a first-line immunotherapy. We can consider atezolizumab and pembrolizumab. If the patient is eligible for platinum, so he should be first given cisplatin, carboplatin, and as a second line, after if it is progressing, then second line immunotherapy we can go for pembrolizumab and this, or switch maintenance avelumab. Then adverse effects includes diarrhea, fatigue, pruritus, autoimmune phenomena commonly associated with PD-L1 inhibitors, including pneumonia, transaminitis, hypothyroidism. These are the commonly side effects in this. So concluding the topic, bladder cancer is one of the most common type of cancers and unfortunately has a high rate of recurrence. The treatment must be administered multiple times and resistance to drugs inevitably develops. Immunotherapy is a promising alternative and checkpoint inhibitors in a particular have gradually emerged as the treatment of choice. However, not all patients respond equally to this kind of therapy and must much research is still needed. Thank you.
You stop sharing and I'll ask you one or two questions if I may.
Yes.
You see, half of my teeth are already gone. Mine. I'm talking of myself. Can you hear me?
Yes, sir. Yes.
If I try to pronounce these therapeutic drugs, all of the teeth will go. What I want to know from you,
yes,
where do you think? Now, let's be simple. I mean, I'm an old man, so there is no point in trying to teach me the whole of the Ramayana Mahabharata of immunotherapy. In summary,
yes,
where do you think immunotherapy is making a real mark? If you are given two choices,
yes,
if you are given two choices,
yes,
money is not a factor, supply is not a factor. Where do you think it has really made a mark? Sir, let's start with NMIBC. Is there any role?
Sir, NMIBC in non-muscle invasive bladder cancer, sir, BCG has been historically and still it is the
BCG. We'll have it tomorrow. I'll take you on tomorrow.
Yes.
But tonight, my question is very pointed.
Yes.
You're a young man, I'm an old man. I know nothing about immunotherapy, but I know something.
Yes.
Where do you think immunotherapy has really made a mark in NMIBC? I'm telling you, I'll give you a free supply of all immunotherapy that you choose. Don't worry about money or supply. Can you tell me, in Calcutta or in eastern zone of India, which category of patient you would wish, I wish I had that? This is a quiz question. I'll tell you what I imagine. You are the teacher now. I'm asking you. In BCG unresponsive, is there a role of immunotherapy beyond BCG? And if so, what?
There is a hint that these patients do not want to have their bladders removed.
Yep.
What do you think?
Sarita, 1, 2, 3 is a disaster. He can't tolerate it. He's just off. You can't actually give him BCG anymore. He's unresponsive. He's got toxic complications. You will not dare touch him. But in your thing, you've got a free supply. Somebody's donated all immunotherapy to you. So, you've got a fantastic presentation. I must congratulate you for that, first of all. Very comprehensive. What it's lacking is, I want a very clear concept as to where do you find the maximum utility. The maximum utility in NMIBC is pembrolizumab, including intravesical pembrolizumab. So you come, we look at it tonight. I'll ask you this tomorrow, if I'm right or wrong. Pembrolizumab has really made a mark. Now move on to MIBC and club them together. And very advanced metastatic.
Yes.
Where do you find the maximum utility? The next slide.
Sir, it has a great use, sir, because in many patients, usually these bladder cancer patients, they have associated, their physical status is not very good, and many of them have raised creatinine. So there are contraindications for cisplatin.
All them, come on, speak the urological language. I know you know more than me. I'm surrendering. My point is, I want your clarity of thought. What you're trying to say is, if they're ineligible for platinum.
Ineligible for platinum based
What are
chemo.
those criteria? Now you've provoked this question. What are those criteria?
Sir, ECOG score, if ECOG score is more than 1, sir, then sir, if GFR is less than 60, then we cannot give cisplatin. If there is any hearing loss more than 25%.
Why do you think? There's something
Sir,
associated with hearing loss also. That will give you the answer. Peripheral neuropathy.
Peripheral neuropathy, sir.
Okay. These are toxic drugs. Now,
Yes,
what I want to say is, I've told you about my opinion about my information, not opinion. I have no opinion because I never used them. The choice in NMIBC is pembrolizumab, particularly intravesical. And there are many other intravesicals which you can use now. It's not only pembrolizumab.
yes, sir.
The other line is when it is platinum ineligible, not cisplatin. When it is platinum ineligible.
Yes, sir.
And the other one is when it is advanced and metastatic. You were talking about atezolizumab. You know what happened?
Yes,
look at this chart. I've given you a summary. I've given you a summary of your long lecture. Atezolizumab was successful and FDA approval has been withdrawn.
Yes.
Okay. Pembrolizumab approved. Avelumab definitely approved. Nivolumab again definitely approved. The durvalumab is the new block on the kit. Again, after approval withdrawn. This is checkpoint inhibitors as second line therapy.
Yes, sir.
Yeah, next. Checkpoint inhibitors as first line therapy. It's still gemcitabine, jugjugio.
Yes, sir.
Whatever might come. Okay. This combination of GC with atezolizumab doesn't work in overall survival.
Yes, sir.
Okay. You've heard of enfortumab?
Sir?
Look at the last slide. EV. Look at the last line of the slide. That's another success story. In my slide. Can you see my slide?
No, sir. Your slide is not visible, sir, in my screen, sir.
No?
No, sir.
Not visible. Enfortumab is a drug. Enfortumab vedotin is a drug which is being used after failure of the first line and second line chemotherapy. So this is the role. In summary, there is a huge role of immunotherapy now that is coming into bladder and is going to change the face of bladder tumor management in the future. Huge life that has come into advanced bladder tumor, and particularly in the early bladder tumor, it is giving new life to the BCG obstinate cases. So much for tonight. I think this is very important for your exam nowadays. That is why Professor Ranjan Dey has put this topic on, very relevant, and I think very topical. I think for the constraints of time, we have got 2 more things to go through. Can we select the next topic as bladder preservation strategy? 5 minutes if you can. I'll stop share. Who is supposed to do this?
I am, sir.
Please carry on. And Demallo and Rohit, you can actually give some comments and questions at the end of it. Who's doing it? Avnish. Yeah? You're silent. You're put on silent. Yeah.
Yes, sir.
Now, very quickly. Very unfair to you, but you have to rush through it and give us the salient features of it.
Are my slides are visible, sir?
Yes.
Okay, so bladder preservation strategy in muscle invasive bladder cancer. So if we go through the algorithm of the muscle invasive bladder cancer, once we find there is a T2N0 M0 in selected patients, we can offer the bladder preserving or bladder sparing therapy. So radical mastectomy is always a standard of care, but it has a high significant perioperative morbidity and mortality, and also the second is 30 days readmission rate. So perioperative complication also higher with the old patients, especially the octogenarians and with the multiple comorbidities. So do we have alternatives? So here we have come with the bladder preservation with the curative intent. We can offer this patient with a high operative risk such as comorbidity and frailty, and the highly motivated patients who have who wants to retain their bladder or who are fit for radical cystectomy with limited burden disease and adequate normal bladder function. So we have option is form of trimodality therapy, monotherapy in form of radical TURBT, partial cystectomy, monoradiotherapy, and monochemotherapy. So trimodality therapy is the most rigorously studied approach, and it consists of maximally safe and visible complete TUR, chemotherapy, and radiotherapy. There are two basic strategies for it. There is a split course and continuous course therapy. So if we see the patients who will be eligible are mainly the bladder tumor with the unifocal less than 4 centimeter. No frank extra vesical extension on imaging. There was no hydronephrosis, no CIS, and it can be grossly totally resectable by TUR, and no contraindication to cisplatin chemotherapy. To meet the criteria of this kind of patient, we have only 6 to 19% patient with MIBC meets to this criteria. So coming to the two variants of the therapy in trimodality, either split course or continuous course. In split course, we do the induction chemoradio with the approximately 40 gray. Then we will wait for the 3 to 4 weeks and restage the disease intermediate with the cross-sectional imaging and endoscopic evaluation. If there is a persistent disease, then invasive form, we offer the patient for salvage radical cystectomy. If it is not, then we continue with the consolidative chemoradiotherapy to the 60 to 40 therapy, and then after we will continue the patient with the surveillance. Continuous course therapy, the same total dose given in the continuous manner, more intensive. So here it is a short period of time given all the therapy, and then after 4 to 6 weeks reevaluate the patient with cross-sectional imaging and endoscopic evaluation. So epitome of the success of the trimodality therapy is a concurrent sensitizing therapy with the mitomycin and 5-fluorouracil should be given to get the as much as effect possible of the radiation therapy, and the quality of TUR. If we see the complete TUR success rate with 5 and 10 year overall survival rate is 57 to 9%, and without complete resection 43 to 29%, which is inferior. So rate of radical cystectomy for visible complete resection are lower when it is completely done, and when it is incompletely, it is a higher chance of patient will have getting radical cystectomy. So 20 to 30% of the patient have a salvage cystectomy in the long terms in form of muscle invasive recurrence, and also as a sequelae of radiation, there is a chance of secondary malignancy also. Here, the more of the prospective studies in form of the bladder preservation therapy, we can see the response rate is almost very in the range of 60 to 90%, and overall survival rate is almost in the range of 50 to almost in the range of 50%. So coming to the unfit patient for the trimodality therapy is very high in severe comorbidities, and there is a concept of therapeutic break even point, where there is a long-term benefit when the patient realizes and versus the patient has facing the short-term risk of morbidity. So whenever the patient has a high higher life expectancy, if the patient has the short-term risk of morbidity is less and long-term it is from the trimodality therapy is expected, so it can be afforded by the patient or vice versa. Now coming to the radical TUR as a monotherapy, it should be when the patient elect for this, patient should be properly informed that there is a chance of recurrence. And the clinical criteria include for the enroll the patient when the patient has tumor size within 3 centimeter, negative risk-stage tumor, no hydronephrosis, no lymphadenopathy, and lack of multifocal disease or lack of CIS. So radical recurrence is based on the primary support as a single modality therapy. When we see the 10% of the cases when the specimen of radical cystectomy, there is only PT0 when without priorly clinical stage T3B. So risk of occult extravascular disease is 25% in the patient with C2, and we see the cystectomy specimen when there is a clinically T2 stage, the pathology T3, T4 chances is 40% and 9% respectively. So it will be under treatment for such kind of patients also. So the long-term survival, long-term outcome by MSK-CC group suggests that when there is no tumor is 74% and residual non-muscle invasive disease is 26%. And 5 or 10 year data shows that the disease-specific survival rate is almost same at the 5 and 10 years, almost 82%, while it is reduces with the non-muscle invasive disease, it is 76 to 57%. Now coming to the patient with the partial cystectomy, it is usually the ideal candidate for it is small solitary tumor away from the ureteric orifice, trigon, bladder neck, no CIS, and we can get the 2 centimeter margin intraoperatively confirmed by negatively by the frozen section and with the good functional bladder capacity. The advantage is we can give with the pelvic lymphadenectomy simultaneously, and we can remove the full thickness of bladder associated with perivesical fat. And this using the strict selection criteria, long-term oncological outcome can be as equal as with the radical cystectomy. Disadvantage, there is a chance of bleeding, intraoperative risk of spillage, and risk of local recurrence is there. Now, radical radiotherapy is a monotherapy should be reserved for the patient with very poor performance and very severe comorbidity. And 10 to 5 years, overall survival is 14 to 90% and inferior to chemoradiotherapy as a combined. When we compare with the cystectomy, responses largely depend upon the stage of the disease, and local recurrence, local control rate has been reported low as a 27%. Prognostic factor to failure is include multifocality, presence of hydronephrosis, and higher clinical stage. So if we combine the external beam radiotherapy, the brachytherapy, there is a reported 5 and 10 year survival rate, overall survival rate, and disease-specific survival rate is increased respectively. Coming to the chemotherapy as a monotherapy, the radical cystectomy, when the patient has offered and the patient has undergone the neoadjuvant therapy and patient has in repeated TUR, there is a T0 and patient not off for the radical cystectomy, and there is a we can go with the we can offer the patient with the chemotherapy as a monotherapy. So on this basis, the predictor of survival with the chemotherapy alone include the small mass less than 3 centimeter, solitary, complete resected tumor without CIS and no contraindication to cisplatinum based chemotherapy. So MSKCC has come out with this study and shown that there is a minimum 5-year follow-up with the 64% of patients were alive and 54% has exhibit intact functional bladder. So with the EUA recommendation, only tri-modality therapy has a strong recommendation, and EU does not support the offer of monotherapy in form of either TUR or radiotherapy or chemotherapy. So post-treatment surveillance should be very vigorously, patient should be surveillance because most recurrence occur within 2 years. Also, there is a chance of late recurrence in form of non-muscle invasive, even at the 10 years. So patient has to stick to the strict follow-up. Cystoscopy and cytology at 3 months in first 2 years, then 6 months for 3 to 5 years, then annually. CCT whole abdomen, pelvis with HRCT, thorax at the 3 to 6 months for 2 years, and then 6 months for 3 to 5 years, and then annually. If there is a recurrence, then management protocol should be based on patient's overall health, time of recurrence, pathological grade, and stage. So low-grade non-muscle invasive recurrence can be treated with the TURBT with the adjuvant intravesical immunotherapy. the high-grade non-invasive cancer without secondary RBT with adjuvant intravesical therapy or salvage cystectomy can be done. Invasive recurrence or high-grade cancer with this second salvage cystectomy is the option. So conclusion is the overall bladder preservation protocol is a shared decision making in the patient who with the proper selection criteria and highly motivated patient who are ready to stick to the strict follow. Thank you.
Thank you. Excellent presentation. I will kick off the first question while the last presentation, upper unit tract, whoever is doing it, please can you get ready? In the meantime, may I ask Rohit and Devmal to take it on? But first of all, my first question, I will kickstart the conversation with you. Suppose in a T2 tumor, he has chemoradiation has succeeded. What is your most important step after this?
So after chemoradiation, I would like to restage tumors.
Okay.
And if there's a restage,
you will restage. That means you have a very strong follow-up.
Yes, sir.
Yeah.
An endoscopic examination.
Carry on, Rohit.
This is the thing that you have to do a rigorous cross-sectional and endoscopic examination in these patients. And that's why TMT is not getting popular because only less than 10% of the patients are eligible. And secondly, the bladder preservation rate is not even 50% in some studies where they have followed the patient for 10 years. So this is the criticism with TMT. Very limited number of patients, and that to bladder salvage is not good when you carry it for more than 10 years.
Yes, sir.
Okay, so in continuity of Rohit Boss's comments, can you now make a precise note about what are the relative contraindications or absolute contraindications of trimodality therapy for bladder preservation?
One is the patient
asked in another way that what are the indications of trimodality therapy? Can you tell me the relative and absolute contraindications of trimodality therapy for bladder preservation?
The absolute contraindication is that if the patient has very advanced disease, also the patient who do not want to follow up very strictly.
No, what is a very advanced disease?
Advanced means, sir, if it is either it is T4, T4B, or if it is clinically sir T3, and also the patient has do not want to stick to the follow-up criteria, also the carcinoma in C2 and the multifocal disease. All these are with lymphadenopathy, all these are criteria not to choose the trimodality therapies.
Okay, so you have already mentioned what you do if there is hydronephrosis in this patient.
Sir, we would like to get diversion in form of sir PC.
No, will you subject this patient to trimodality therapy or not?
Sir, before trimodality therapy, sir, I would actually, sir,
Counsel the patient that yes.
Hydronephrosis is suggestive that it is already muscle invasive, and if there is no other imaging source, there is no T3C, then I would suggest patient with the trimodality therapy.
Okay, so you now get a patient who a 65-year-old lady who received prior pelvic radiation for say cervix. Now she has presented with a 2 centimeter muscle invasive tumor at the dome, and she is willing to preserve her bladder. Would you advise for or against preservation of bladder in this patient?
Sir, I would advise her against the bladder preservation.
Why?
So first of all, the dome is the area where the restage TUR and TUR is very difficult. Means resection of complete is very difficult. Another thing is that patient has already received the radiation therapy. There is a chance of pelvic pelvic anatomy distortion and also the involvement of the bladder and the bowel is very much affected. So when with the follow-up, we will not get enough the patients.
Will you give her a chance with partial cystectomy?
Yes, sir. If I'll able to get this a 2 centimeter margin with intra-frozen section, I would like to give a chance of partial cystectomy.
Would you offer an lymphadenectomy with this partial cystectomy?
Yes, sir.
So prior pelvic radiation, where you want to do an partial cystectomy, maybe she has gotten cobalt radiation previously. It is very difficult to do an lymphadenectomy in these patients. You can do a radical cystectomy in this patient, but as you said, that the pelvic anatomy and the nearby GI anatomy may be altered. So prior pelvic radiation is an absolute contraindication for an trimodality therapy. So the depth of the tumor or the involvement of the adjacent organ. Will you suggest a patient of T4A to have a trimodality therapy?
No, sir.
T4B?
No, sir.
T3B, T3A?
T3A, sir, also there's a chance, I can explain the patient that there's already, means there is also chance of recurrence, so also I will not suggest the patient with T3, only sir T2.
Okay, so there is a patient who had an spinal cord injury way back and has poor bladder function. Would you advise a bladder preservation strategy in this patient?
No, sir.
Excellent.
Can you summarize, Devanlo, can you please summarize it for them? There are clear messages in your questions.
So the clear message is, so there is, as Rohit boss said.
Sorry, let me interrupt. Let the other person get ready with your sharing. And we'll, in the meantime, Dr. Ganobadai will actually give you the final verdict on the principles of trimodal therapy.
So there are a lot of criticisms against trimodality therapy, and it has not seen the success as it would have. So the ideal most patient who is a T2 than 2 centimeter T2 tumor, who does not have an hydronephrosis, who does not have carcinoma in situ or diffuse involvement, a complete TURBT can be done, and you are very sure of that you have done a complete TURBT. It is an unifocal tumor, and the patient must have a good bladder function. This is an ideal patient who can preserve his or her bladder in the future. Again, in continuity of the previous presentation, if these patients are of less than ideal nature, in these cases, an immunotherapy can help for bladder preservation. But less than ideal patients have somewhat limitations for bladder preservation. That is why bladder preservation is not the champion of management of muscle invasive bladder cancer.
One final question. What is radical TURBT? Difference between radical TURBT and routine TURBT?
While you're answering this, can you stop sharing so that the next person can put up the screen, please? You keep talking, but please stop sharing. Yeah, okay.
Radical TURBT, sir, we completely excise the tumor until we see the till the extravesical fat. We have to take out all the muscles there, sir, including the detrusal muscle in the TUR space.
Very, and you should be able to
Can't hear you. Okay, you can answer it tomorrow. You're not audible. So can we move on to the next? This is a very important question, but we'll address it tomorrow again. What is the who's presenting this, please?
I'm presenting, sir. Yes, sir.
Yeah. Please be precise. We'll have a short discussion and we close for tonight. Yeah.
Okay. So I'm presenting on the management of upper tract transitional cell carcinoma. So just I'll leave this. So most of the upper tract congestive cell carcinoma presented as a hematuria, gross or microscopic. It may presented as a flank pain or or acute renal colic pain. Patient may have systematic symptoms. In 50% cases, they discover incidentally. So for the management, we have to diagnose first. Then we'll stratify risk. We'll do risk stratification. Then we'll do treatment according to them. So for that, we have imaging. We have to confirm. We have to diagnose the particular urothelial cancer. So what we have different investigation and diagnostic modality. First, we can do ultrasound. So in ultrasound, transitional cell carcinoma appear as a hyperechoic as compared to the surrounding renal sinus and renal parenchyma. And occasionally they may present as a mixed echogenicity. The characteristic of transitional cell carcinoma is, in spite of being infiltrative, the renal reniform shape is not disturbed. The renal counter is not disturbed. So here we can see the transitional cell carcinoma. There is a hyperechoic lesion in the upper pole as compared to the renal parenchyma. This is the case of renal cell transitional carcinoma, 59-year-old female. Will build defined hyperechoic mass in the upper lesion. So for ureteric transitional cell carcinoma, ultrasound has a limited role. If it is visualized by ultrasound, this tumor are typically intraluminal soft tissue masses with proximal distension in the ureter. And USG also have a limited assessment for the periureteric extension. For that, we have to do cross-sectional imaging in the form of CT scan. The CT scan is investigation of choice. So it has sensitivity of 100% and specificity of 60%. So the advantage is we can capture the multiple phases of contrast expression in less time. So the typical finding of urothelial cancer is a sessile filling defect ranging from 10 to 17 Hounsfield unit. The average is 46 Hounsfield units as compared to the RCC. RCC has a little bit denser, and so there for the filling defect and for the dense lesion, we have few differential diagnosis which we have to rule out. So our first differential diagnosis will be ureteric calculus. So ureteric calculus, even the radiolucent ureteric calculus is of more than 100 HU. So we can differentiate by Hounsfield unit. Blood clots are having a density of 50 to 75 HU. There may be slough papilla or fungal bulb, but they do not enhance on the excretion. The other finding will be a pelvic calyceal irregularity, focal or diffuse mural thickening in case of malignancy, or focal obstructed calyces. So even advanced transitional cell carcinoma extending the renal parenchyma, however, the reniform stem is typically preserved. Unlike the RCC, in RCC, there will be renal parenchymal architecture is disturbed, and there will be early enhancement after the putting IV contrast as compared to the RCC. So we can see, and this is the non-contrast film, and we can see this is the urine, and this is the arrow suggestive of dense lesion as compared to the urine and the renal parenchyma. On the contrast, this is the arterial phase. You can see there is a early enhancement in the arterial phase and the filling defect in the renal pelvis. So this is suggestive of upper tract transitional cell carcinoma. And in the this is the huge on the left side, there is a huge transitional cell carcinoma. So in this case, we can see the reniform shape is well maintained in this case. So the next imaging is magnetic resonance urography. It has very less role in the upper tract transitional carcinoma. It is only should be done in case of where CT could not be done. FDG had sensitivity and specificity of 82 and 84%, but their role of FDG is very less, and it is not recommended. Actually, we can do for metastatic workup in case of if we suspect lymphadenopathy in the imaging. So the other diagnostic test is cystoscopy. Cystoscopy is mandatory to rule out the concurrent bladder tumor. And the ureteroscopy. The ureteroscopy is a ureteroscopy should not be done in all cases. It should be reserved for doubtful cases where urine cytology is positive and there is no radiological evidence of any tumor. So by doing ureteroscopy, we can do breast biopsy or punch biopsy. But by doing punch biopsy or breast biopsy, staging is not accurate because the depth of the tumor could not be assessed. So the risk of the tumor seeding and extravasation and dissemination is present while doing ureteroscopy, but the incidence is very less. So if we combine the ureteroscopy with the cross-sectional imaging, there will be increased diagnostic accuracy by 75 to 85% to 90%. So this is the ureteroscopic feature of the upper tract TCC. So next investigation is retrograde pyrography. It has
We need to rush through this. We don't want a full lecture on this. I want in salient topics. What are the controversies and management? This is not on. We know all this.
So there are recommendation. We have to perform. We have to perform ureterocystoscopy, rule out the bladder cancer. There is a strong recommendation, and we have to perform CT geography for the diagnosis and staging. And the ureteroscopy, it should be reserved in case of if the diagnosis is doubtful. And for the MRI and FDG PET, there is weak recommendation. So this is the staging. So for the management of upper tract urothelial carcinoma, we have to stratify in the low risk and high risk patient. The low risk patient will be if there is a unifocal disease.
No, which is low risk and which is high risk. Now, what is the management? Tell me.
So for management of urine cytology positive or carcinoma in situ cases, we have to confirm the positive urine cytology. Then we have to do upper tract imaging. If the upper tract imaging is negative, then we have to do cystoscopy and bladder biopsy. If the bladder biopsy is positive, then we have to treat as a bladder cancer. And if there is negative, then we have to think about the extravesical evaluation. And if the upper tract imaging is positive, then we have to go for upper tract evaluation and the treatment. So this is the algorithm. If there is a filling defect or radiological suspicion in the upper tract TCC, so we have to rule out the calculus. And if doubtful, we have to do ureteroscopy with the biopsy of the lesion, and we have to stratify the risk. And if there is a disease or low risk and organ confined, then we have to do conservative therapy. And if disease is high risk and organ confined, then we have to go for radical nephrouretectomy. So the management for the localized high-risk disease is the open or laparoscopic or robotic nephrouretectomy. So what is the principle should be, we have to be outside the xerotus fascia, and adrenal should not be removed in all cases. It should be removed only if there is intraoperative finding suggestive of infiltration, or radiologically it is suggestive of metastasis. Management of bladder, management of distal ureter and bladder cuff. The entire distal ureter, including the interluminal portion and ureteral orifice, has to be removed to reduce the recurrence. So this is the approach. We can go for either a midline single incision, or we can go for flank incision or subcostal incision. In that case, we have to need additional incision for the lower ureter and bladder cuff.
We'll go on. Next slide. Yeah, we know all that. Yeah.
So these are the techniques after the distal the techniques of the distal uretectomy. So traditional open distal, either we can do transvesical ligation or transurethral resection or intussusception or total laparoscopic technique. But our principle should be we have to choose a technique which has less recurrence rate, and there will be less chances of spillage. So in case of intussusception and transurethral resection of urethral orifice and transvesical ligation and detachment, there is a spillage of the tumor. There may be chances of spillage of the tumor into the extravesical space or into the bladder. So this technique should not be preferred nowadays. So these are different techniques. So this is the intussusception. In the total laparoscopic technique, we have to remove the whole specimen, kidney and ureter with bladder cuff, and we have to apply the staple at the distal end of ureter and the bladder. The disadvantage of this is that we can't comment of this margin, the bladder margin and distal ureter margin, because due to the stapler, some studies suggested that the margin could not be assessed properly because of the distortion due to the stapler. So this is the concern. Leaving the ureter mucosa within the staple line and inability to pathologists to evaluate the distal margin because of the presence of a staple. So the contraindication for this technique is if the tumor is located in the distal ureter, so we have to avoid this laparoscopic technique. So what is the impact of complete resection? The risk of tumor recurrence in recurrence is in the uretral stem, which is 30 to 75%. So the plug intussusception and stripping technique are abandoned nowadays. This is a total laparoscopic technique. So for the removal for the muscle invasive and lymph node positive disease, there is a controversy whether we should go for a template lymphadenectomy or not. There is no clear-cut RCT. So for the right side, which template we should remove? For the right side, we have to remove paracaval, retrocaval, intracaval lymph node, and for the left side, paracaval, aortic lymph node. These all are hilar lymph node. This should be removed for the upper pelvis or upper ureteric tumor. And for the middle one, we have to remove inferior mesenteric artery template also. And if there is if the upper two-thirds of ureter involved, then the template should be extended up to the bifurcation of the aorta. For the distal ureter, we have to remove pelvic lymph nodes. So the conservative approach, should be given for the low risk patient, low risk patient and low risk unifocal patient. So the what are different conservative approach? Open segmental uretectomy. It should be offered for upper and middle 1/3 of the ureter, and the principle is we have to remove 1 to 2 centimeter margin proximally and distally. And distal uretectomy and direct neocystostomy or ureteroneocystostomy with bladder cuff muscle hitch or Bowery flap can be applied for the distal ureter low risk patient. And this should be offered for the patient in which the tumor could not be resected endoscopically completely. And if the tumor is involving the more length of the ureter, then we have to replace the ureter by the ileal ureter replacement. And in the export center, we can do renal auto transplantation also. So the distal uretectomy and neocystostomy may be offered for the low grade, low stage, or in selected cases, a high grade locally invasive bladder tumor where kidney preservation is necessary, like solitary functional kidney. In that case, we can offer in high grade also. So what is the difference between open and laparoscopic management? The advantage of ureteroscopic approach is that we are dealing in a closed system, and we are not going to open non-urothelial part. So this is the advantage. And for the conservative management, we have antegrade and retrograde. Antegrade and retrograde approach. For the retrograde approach, advantage is we are dealing in a closed system. We are not exposing non-urothelial tissues. The disadvantage is that we are having a small instrument, a small field of view, and a small working channel. So the removal of bulky tumor is not possible through the ureteroscopic, and there will be difficulty in assessing the lower pole tumor, and there is difficulty in a patient with prior urinary diversion. So we can't locate the ureteric orifice. The advantage of percutaneous is that we can remove the large bulk of the tumor, and the disadvantage is that in this case, patient is having high morbidity, and the better it is preferred for the lower calyceal and large tumor. The other advantage that we can put the nephrostomy tech for the maintenance of immediate post-operative nephroscopy, relook for the relook therapy or adjuvant therapy. So these are the endoscopic resection method. We can apply either retrograde or in integrate method. We can remove the tumor by the basket with piecemeal, or we can resect with a monopolar cautery, or we can apply the laser. So in a laser we have two options: holmium laser or Nd:YAG laser. So the advantage of holmium laser is that it has less penetration and efficient ablation of the tumor. So our principle should be we have to remove all the visible tumor, and we have to take the separate biopsy from the base, and we have to fulgurate the base to prevent the recurrence. So these are the studies which suggested the recurrence, and they all are following up to the more than 50 months, and the recurrence rate is about in some studies that the recurrence is 30%. In some studies, the recurrence is more than 50%. And this is the summary of the studies in which ureteroscopic management has been done. So they follow up for the follow up most of the follow up for 50 months, and the recurrence is, you can see there is a high recurrence as compared to the.
So tell me, I'm interrupting this, but tell me, what management of upper tract TCC have you seen in your department?
Sir, we are doing radical nephrorectomy with bladder cup excision, sir.
तुमको खाना खाने बोलते तो खाना आगे खा लिया करो, वो तो काम बाद में भी होता रहेगा.
Okay, so what have you done in a renally compromised patient?
Sir, renal compromised patient, we can go for conservative management, but we have to explain the morbidity of renal replacement therapy and the morbidity of this conservative therapy and the chances of recurrence. The recommendation says that the morbidity of renal replacement therapy is less as compared to the morbidity of recurrence in conservative management.
So what does that mean?
It means we have to give maximum oncological benefit to the patient.
So what will you do in a mid-ureteric TCC, which is around 2 centimeter in a solitary kidney? What will you do?
Sir, if it is low grade, I'll do, sir, ureterostomy. I will do uretectomy, keeping 2 centimeter margin, and do ureterostomy.
If it is a high grade tumor?
Then, sir, I'll do nephrouretectomy and keep patient for the renal replacement therapy, sir.
Okay, so in most of the centers, what you have described here is good, but in most of the centers, the most important conservative treatment which can be done is in lower ureteric tumors, isn't it?
Yes, sir.
If it is low grade, then you can do a straightforward distal ureterectomy with new reimplantation. And if it is high grade, you have to add pelvic lymphadenectomy along with this thing.
Yes.
Isn't it?
Yes, sir.
Okay. So are you willing to do a percutaneous? What are the logics against percutaneous treatment? What are the criteria? What are the criticisms against percutaneous treatment?
Sir, percutaneous treatment, sir, first the morbidity is more as compared to the retrograde endoscopic management.
Even more than that, what is more important?
And their tumor shedding, the chances of tumor shedding is in percutaneous. conservative therapy.
Absolutely, that is I think right. There is chances of tumor seeding. What is there any role of retrograde intrapelvic instillation following conservative therapy?
Yes, sir.
It's theoretical, although.
Yes,
Is
sir.
there any role of retrograde upper tract instillation in case of conservative therapy?
Yes, sir. In case of low grade, we can go retrograde, sir.
And what are the logics against that? What are the criticisms against that?
Criticisms is that if the tumor is in the lower pole, we can't
No. Retrograde.
retrograde. Yes, sir.
I mean, you have done a flexible ureteroscopy. You have removed a tumor with laser,
Yes, sir.
which comes out to be a low-grade TCC, maybe 2 centimeter in size, in renal pelvis.
Yes.
What will you do in this patient? Will you prefer to use any post-ablation intrapelvic instillation, or would you prefer to keep this patient in surveillance only?
Sir, I'll do, sir. Integrate, I would like to do adjuvant therapy, sir, after ablation, sir. How? Sir, during integrate approach, we will keep nephrostomy.
No. You have removed this with a flexible ureteroscopy, isn't it?
Okay.
Now you need to grab this concept while you were discussing ureteroscopy for diagnosis. When you are in doubt that
yes, sir,
it is not radiologically possible
and cytology positive,
identify the lesion, then you have put in an ureteroscope. What kind of ureteroscope is that?
Sir, flexible ureteroscope.
It is recommended that you put an flexible ureteroscope in, isn't it?
Yes. No, sir. But nowadays, flexible ureteroscopy is being done. But semi-flexible ureteroscopy should be.
But semi-rigid ureteroscopy can also be a ureteric tumor.
Yes, sir.
Okay. So you have removed it with laser with a flexible ureteroscope. What will you do then? Will you observe the patient only? Or you would like to use an intrapelvic instillation?
I think you summarize it and we close. Can you summarize the thing?
So it is nowadays not at all recommended to keep the patient on intrapelvic instillation while the tumor is managed in retrograde manner, because while you can use an ureteric catheter for that, but that has to be kept with the patient. But if you use a DJ stent and instill inside the bladder and hope that it will reach the pelvis, this is not proven. So for all practical purposes, it is better to do an radical nephroureterectomy with a bladder cuff excision with or without an template lymph node dissection in case of upper tract tumor, rather doing an conservative management, even if with the risk of renal replacement therapy.
Yes.
Okay, I think we close the discussion for now. We will continue tomorrow. Thank you very much. I think
thank you.
3 students really did marvelous presentations. My comment, if you ask me, a piece of suggestion, you have to learn how much to say, when to stop, just like any surgery. Because all this effort that has been made is not to teach you, because you know better than us. We were here as guardians of what you are delivering, what you are being asked, and what appropriate answer with logic you are being able to present. It is very, very important to think before you answer. And whatever you answer, you must have a very strong logic. There's no question of any argument with the examiner or anybody. Best not to get into any controversial statement. We will carry this discussion on. If I were to give marks to the three presentations, I think the immunotherapy stands best. I will not comment on ranking. I think well done, everybody. I think you really know a lot, which is very encouraging. Your presentations are extremely detailed. My only suggestion is, in your life, try to be more crisp and appropriate. Tomorrow, 10 o'clock, we discuss three more important subjects, which should help you to think how appropriately you can face the subject of bladder tumor. There is no way we can teach you anything within these 2 or 3 hours. So be ready that we are not going to be comprehensive. We are going to guide you in the most controversial areas that are possible, and 1 or 2 things which will be for training. So tomorrow, 10 o'clock, we meet again, and we hope to finish 2 or 3 important subjects, and we hope to get a few more examiners. I think we put a lot of strain on the 2 examiners. Thank you very much, Rohit and Nirmala, but that doesn't put you off the hook till tomorrow. You will still have to be there tomorrow. I think Shoman has been a very musical person. By the way, before we sign off, Avanish, are you in Norway or wherever? Where are you?
Sir?
Where are you? Are you in Norway or where are you?
No, sir. Actually, I'm in department, sir, but the background is
got beautiful backdrops. So on that note, we have better backdrops and better discussions tomorrow. Good night, everybody.
Thank you, sir. Good night, sir.
Thank you.